Hello. Hello, good morning, everyone. Thanks for joining us for this morning's educational webinar. We'll give everyone a few more moments to log in and get settled. So hang tight, please. And hi, Neelam. Good morning. Hi, Mark.
Hi, Tara.
Oh, here's some fun music. All right, good morning, everyone. We'll just give it another couple moments. We have lots of people logging in just at the moment. Okay. All right. We might have some more people join us, but I'll go ahead and try to get us started with just a couple housekeeping items. First and foremost, if you're not presenting or asking a question, if you could mute yourself, that would be great. So thank you for being mindful of our presenters this morning by doing that. I'm Tara Chetok, and I'm the project manager of the Oregon Health Policy Board. And we hold these educational webinars as an opportunity for the board members, staff, the public, any interested parties to join us to learn more about upcoming topics that the board will be discussing and reviewing. And today we have with us Neelam Gupta and Mark Overbeck with the Healthcare Workforce Committee, who will be presenting their work on their health equity framework. And they will be joining us at the October board meeting to share how this framework fits into the final report. And they'll also be touching on a couple other project areas that they're working on. But before Mark and Neelam kick us off, I just wanted to remind everyone that the educational webinar is for informational purposes only, and no board business will be conducted. I ask that everyone can remain muted during the webinar, but certainly if you have a question, please raise your hand. You can send your question in the chat box, and we will take questions through. It looks like I was accidentally muted. We will take questions throughout the webinar as an opportunity for members to learn. So we will prioritize questions from the members, but certainly if staff or other members of the public have questions, we will try to get to those pending time. I'll go Neelam and Mark introduce themselves and introduce today's topic.
Hi, good morning, everyone. My name is Neelam Gupta. I'm the director of the Clinical Supports Integration and Workforce Unit in the Health Policy and Analytics Division at OHA, and I use she, her pronouns. Mark, would you like to introduce yourself?
Thank you, Neelam. Good morning, everyone. My name is Mark Overbeck. I work for Neelam as the director of the Primary Care Office within Oregon Health Authority and the Health Policy and Analytics Division, and I use he, him, and they pronouns.
Great, thanks. Well, we're so excited to come to you this morning and to provide this presentation on our work to develop an equity framework. Next slide, please. So we're going to start by reviewing the purpose of the framework, and then give you some background on the methodology, what went into the development of the framework, and then also review some recent activity that the Healthcare Workforce Committee has undertaken, as well as investments that have occurred in the healthcare workforce for Oregon providers as a backdrop. Then we really want to spend the majority of the time reviewing with you what we heard through a series of listening engagements. We have been listening to over 25 groups over the last few months, and are really wanting to share that with you and to get your feedback. Then next we will review with you guiding questions that we have developed for our equity framework. And then some ideas we have for staying connected and moving forward with the groups that we have listened to. And I apologize for the typo in the last bullet. Then we have some questions for the Oregon Health Policy Board members that have joined us this morning. Next slide, please. So this is Oregon Health Authority's health equity definition. We put it up here because we want to stay centered in equity and grounded in this definition. You know, and we recognize that there is still a lot of work to do, and we put it up here so that way it serves as a reminder, and we can continually refer to it as we undertake this important work that will ultimately redistribute resources and power and rectify historical and contemporary injustices. Next slide, please. So the purpose of the equity framework is to develop a set of values and principles that will allow the Healthcare Workforce Committee to review funding recommendations on allocating resources and consider conversations related to the future of the healthcare workforce in Oregon. This has been work that the Healthcare Workforce Committee has been very intentional in doing and really wants to get it right. These discussions, you know, to develop an equitable workforce that delivers culturally responsive care have taken on a new urgency as a result of the COVID-19 pandemic and the stark inequities that have been exposed and highlighted.
And Neelam, if I could jump in for one moment. Many of you, certainly on the Health Policy Board, are aware that the Healthcare Workforce Committee has been engaged in this endeavor to develop a substantial, meaningful equity framework for some time, really over a year. And as the board adopted the definition of health equity, we as staff working with the committee understand that we're speaking about the redistribution of power and resources. The Workforce Committee is absolutely clear that it needs to be retooling, rethinking its own processes, its own deliberations, its own conceptual framework for how it makes its decisions, what it discusses, and that includes recommendations around the allocation of resources, whether they're large resources in size or small. But that's also some of the background of the equity framework that I think it's important that we share with you. And lastly, also want to acknowledge that the Vice Chair of the Workforce Committee, Laura McKean, I saw is in attendance, and of course, our liaison from the board, Brenda Johnson. Thanks, Neelam.
Great, thank you. Thank you so much, Mark, for providing that additional information and context. Next slide, please. So the equity framework was developed through an analysis of really 3 sources. We started with doing an analysis of various reports, needs assessments, and surveys, reflecting community and worker voices. We recognize that this information has been shared by community in different forms and venues. And we really wanted to honor that information and recognize also that during this time, we are all approaching the same set of folks, and we really wanted to try to minimize listening fatigue. So based on that analysis, there were some gaps, and we then proceeded to contact some community groups, and we engaged in over 25 listening sessions that were conducted with organizations statewide and locally, that were preceded by a series of trainings in constructivist listening, which really provided the committee members and OHA staff an opportunity to learn how to listen deeply, how to listen to community members, and provided us with different listening techniques. This came about when we were initially having discussions about doing these listening engagements, and one of our committee members expressed, I would really like to have an opportunity to learn more about how to listen to community members and groups I haven't frankly engaged with in the past. And that was provided by the Cross-Cultural Health Program, which is a wonderful organization based in the Seattle, Washington area. And then the third source that we used was Healthcare Workforce Committee, Oregon Health Policy Board, and other primary care office reports and discussions. We drew on the recent work with the Healthcare Workforce Needs Assessment and all of the really rich dialogue that has taken place over the last year and a half. The primary care office collaborated with a patient-centered primary care home program in gathering and analyzing these sources. The unit that I direct, the Clinical Supports Integration and Workforce Unit, is relatively new. It started last September, right after I joined OHA, and it brings together the primary care office and the PCPCH program into a single unit, really to have focused and we also then lastly looked at information on recent activity with the Healthcare Workforce Committee and investments to provide additional context. And so I'm going to hand it over to Mark to go over these next few slides.
Great, thank you, Neelam. If we could have the next slide, please. Great. One of the items that we did, Neelam had referred that we wanted to avoid, where possible, listening fatigue. So part of that strategy also, rather than asking people over and over and over and over to please meet with us, we did a document review or a document analysis by staff where there were already many groups that had provided to OHA or the Health Policy Board a very comprehensive assessment of how things are from their perspective and what needs to alter to approach health equity. So this list here is a partial list of the documents that we analyzed, rather than asking, for example, the Coalition of Communities of Color to come back and do yet another listening engagement. Thanks. Next slide, please.
Mark, I'll just add on. We
Sure.
analyzed probably about over 25 different documents representing a wide range of different community viewpoints.
Thanks, Neelam. And here on this slide, you can get a sense of the breadth of the groups that we did directly engage with. They range from commissions and committees of OHA and the board, such as the Health Equity Committee, the Traditional Health Worker Commission. We did an engagement with tribes. It also ranges from what you might call hardcore workforce organizations, such as the Oregon Workforce Partnership, which includes the 9 different workforce board directors, the Urban League, which provides workforce services, and ranges to statewide and local organizations that provide services to communities of color or advocate for communities that have been historically underrepresented, such as, I won't list them all, you can read this, Project Access Now, Apano, ERCO, Self-Enhancement Inc. It was really a very a thoughtful approach, and I'd say a fairly broad approach in meeting personally with organizations and then also doing the review that was identified in the previous slide from those groups who had already presented one or multiple times to the board and or OHA. Thanks. Next slide, please. And then we also have primary care practices and organizations. Given that the patient-centered primary care home program has extensive relationships with primary care practices, as does the primary care office, we look to leverage those existing resources to get to organizations that are currently providing primary care to get their views of, if we're going to move to equity, if we're going to have a workforce and a healthcare system with equity at its core, what needs to happen. And here's a sample of those primary care practices. They range from Winding Waters, that I know the board is very familiar with, Prism Health, Central City Concern, Options for Southern Oregon, and then there's this also really great community health center organization that we are about to engage with, named La Clinica, on the list. Thanks very much. Next slide, please. Good. So, Neelam, does it work for you if I go to the Race and Healthcare Workforce Committee activity next? I think that's what we said we would do. Just checking.
Sure. Yeah.
Okay. So, as Neelam had shared, those listening engagements, the document review was engaged with by the OHA staff and Clinical Supports and Integration Workforce Unit. The highlighted listening engagements were also attended by a member of the Workforce Committee. So now we want to go back and set a little bit more context of some of the recent activity from the Healthcare Workforce Committee itself. So first of all, November 2020, we had the most recent evaluation published of our healthcare provider incentive program. That's the now more than 3-year-old program where the legislature had directed OHA to develop a program that would provide incentives to clinicians across the spectrum in physical health, oral health, and behavioral health. That evaluation was published and reviewed by the board and the Workforce Committee. We also have February 2021, as members of the board you're familiar with, the most up-to-date needs assessment of the healthcare workforce. That was led by Craig Mossback, who I see is also on this webinar. So around supply and distribution, we've had those reports. In terms of the composition of the workforce, the last diversity of the workforce report was issued in January of this year. I think you may have received it in February. There have been presentations on how do we need to develop our workforce starting very upstream, starting middle school, high school. You've had presentations on telehealth, telemedicine, and both real opportunities and also the current challenges with that. And finally, the Workforce Committee has also had several presentations in the last 6 months around clinician burnout and efforts around the state to increase the resiliency of healthcare providers and health professionals. So all of this is a set of activity that the Workforce Committee has been engaged in over the last, now really eight to 9 months. Thank you. Next slide. And then, of course, there's no context like funding. So what we're sharing here is a reminder of, for the 1921 biennium, given we've had the Healthcare Provider Incentive Program, here are the provider incentives that have been available for clinicians in the state of Oregon. First of all, at the top of the screen, there's the tax credit, which is not a direct incentive payment. It is money that goes to clinicians in rural areas that has been not available to the general fund. So essentially is a payment, of course, and an investment by the state. And then we have the categories of loans, grants, and subsidies, specifically loan repayment, scholarships, and loan forgiveness, and non-financial incentives. The green buckets, if you will, represent direct investments by the state. They range from loan repayment for behavioral health clinicians and what we call primary care loan repayment, which has really been primary care for medical, oral, and behavioral health. They range to scholarships that have been provided to many Oregon educational institutions to make available scholarships for people in their schools to undergo training in exchange for a commitment to practicing in an underserved area. They include the How To Grant program, which you're very familiar with, and they also include direct subsidies such as the Rural Medical Insurance Liability Subsidy for physicians and nurses who work in rural parts of the state. And then the red buckets represent federal investment. Oregon's very, very privileged to have a very strong suite of state-funded investments in the healthcare workforce that have gone along and complemented what the federal government has made available and that we've taken advantage of in Oregon. Thank you. Next slide. This is another way to represent the total of those green buckets. We've had allocations made by the board for the 1921 biennium, and this is largely how that 17 million plus about $2.5 million carried over from the previous biennium was allocated and in fact spent over the last biennium. And this investment has made a tremendous difference. I'm not going to go through the chart itself, but you can see here, this has really been the distribution of the 17 million from the legislature plus about $2.5 million in carryover from the previous biennium. Happy to take questions at the end about any of these individual incentives. Thanks. And then the next slide. Board members, you'll recall that due to your efforts, an additional $2 million for loan repayment was provided and earmarked specifically for behavioral health professionals, both those licensed and those non-licensed, working toward licensure, as well as those professionals we call QMHAs, who are associates and not necessarily working toward licensure. What's reflected here is new behavioral health workforce funding. And as you know, the legislature through House Bill 2949 allocated $60 million in monies for incentives for behavioral health professionals and an additional $20 million specifically to expand clinical supervision and clinical practice opportunities for those working toward licensure. HPA is and will be working very much in tandem with the Health Systems Division and the Behavioral Health program to identify exactly what are the strategies, how should these monies be spent, We've got the $80 million mark, but please don't think that any of this has all been determined. We are very early in our process of, in collaboration with Health Systems Division, looking to hire staff and to have a advisory council and a governance structure set up that is reflective of the community-led and equity-focused approach that we're committed to taking. The next slide, please. All right, now I'm going to kick this then back to Neelam to summarize what actually was heard in the listening engagements. Thanks.
So we took all that information that we gathered through those listening sessions and summarized it into 7 key themes. The first theme that we heard was around a need for pipeline development and career pathways. Mark referenced that the Healthcare Workforce Committee received presentations on upstream pipeline development. And so we heard, specifically that stakeholders were very interested in providing middle and high school students with opportunities to have career exposure, have internships, and then have ongoing mentorships. In order to address what some have termed to be a leaky pipeline through which people fall through and then don't enter a health profession career pathway. The next area we heard about was really providing people who are currently in the workforce, as well as those who have been displaced due to the economic downturn with the pandemic, with career advancement opportunities. Are there opportunities to provide people who used to be in the retail sector to enter the healthcare workforce, given that there are some shared skill sets and competencies? And then lastly, we heard a need to better align and coordinate with Oregon's statewide workforce system that exists outside of OHA, really to create a no wrong door approach to career advancement. The second area we heard a lot about was the education, training, and credentialing. We recognize that education institutions have done a lot to improve their admissions practices to attract and admit more people of color, but we heard that there still is bias that exists in testing, in admissions practices. The second area we heard about was there could be an opportunity to prepare international health professional graduates to practice in Oregon. One example is the primary care office has the J1 physician visa waiver program, but are there other opportunities to do this? The third area we heard about was, it's difficult for people from diverse backgrounds to wait for reimbursement. And so, there's a need to fund scholarship and education costs up front. We also heard the need to address student debt, and in particular for occupations receiving lower wages, which may have a more difficult time paying back those funds. And then lastly, we heard about the need to provide paid on-the-job learning for those entering careers. A lot of what one needs to be successful in the workplace is very specific to that workplace. And also there need to be wraparound supports, such as childcare, transportation, and other similar supports. Next slide, please. The third area we heard about was recruitment, hiring, and retention. The need to implement recruitment processes and strategies to ensure a diverse candidate pool so that people from diverse backgrounds make it into consideration for jobs. The next area we heard about was addressing bias in application, screening, and interviewing methods. So that way, once people from diverse backgrounds apply, they are considered for an interview and have an opportunity to advance and become employed. The next area we heard about was create a supportive work environment for staff from diverse communities. We've heard through the PCO's work with various healthcare providers that does not always exist. And a lot of providers from different backgrounds will leave their workplace as a result. And then lastly, the importance of implementing strategies to retain diverse talent, providing mentorship, providing leadership development, and in particular for those diverse staff at the lower end of the wage spectrum. The fourth area we heard about was compensation, the importance of addressing structural wage inequities, especially for unlicensed and behavioral health occupations. In the recent legislative session, House Bill 2086 includes a living wage study for behavioral health occupations. But that this is a big issue. And then another area was really increasing reimbursement rates targeted to wage increases. That sometimes those increases in reimbursement don't make it to the worker level. Next slide, please. The fifth area we heard about was culturally responsive services and practice environments. Again, really to create a welcoming practice with a workforce that reflects patients served. When patients from diverse backgrounds come into the practice, do they feel that that's a place that will serve their needs? Do they see artwork that reflects them? Do they see staff that reflects them? Do they feel that the trauma that they may have experienced will be addressed adequately? The next area we heard about was, really including professionals and care teams that have skill sets to provide integrated care. And then the last area we heard about was providing services in between visits to address gaps in care. Could it be using traditional health workers or other modalities like telehealth? The sixth area we heard about was structure of incentives. Really designing incentives to address health profession shortages not covered by traditional scholarship and loan repayment programs. Mark referenced the $2 million behavioral health loan repayment incentive. We're really excited about the potential through HB 2949 investments. And we recognize that we need to do more in this area. And then lastly, really providing those wraparound supports to incentives, sign-on bonuses, housing, especially in rural areas where that's an issue. Also providing peer support and mentorship. And then the last area we heard about were other issues, the need to hire and retain diverse staff and to advance them into leadership positions. providing, you know, again, professional development to lower wage staff. We heard that often those professional development activities only are for those in management. And in order to promote that career ladder, lower wage staff also need those opportunities. And then, you know, we heard overwhelmingly, you know, the need to build trust with diverse communities. Next slide, please. So, you know, based on everything we heard, we have put together, you know, these guiding questions that we intend to use for the equity framework, you know, that will really give us an opportunity to apply them to the healthcare workforce committee's investments and advanced opportunities for creating an equitable workforce that really provides culturally responsive care to underserved communities. So you'll see that, you know, some of the questions look at who are the groups that are affected and what is the potential impact of this allocation and strategic investment. You know, do these investments ignore or worsen existing disparities, or do they produce unintended consequences? You know, there's another question that asks, you know, how are we collecting real D and SOGI data, you know, in our awards and matching those, you know, those demographics with the communities we're serving? And, you know, how are we resourcing and influencing system partners to ensure programs optimize equity? Next slide. So some of our ideas for continuing to stay connected to this wonderful cadre of groups that we've gathered and listened to, we expressed to them that our intention was not just to listen once, but really to develop an ongoing relationship, because we recognize that we need to continue to remain engaged and continue to listen in order to really meet the 10-year goal that OHA has set forward of eliminating health inequities. So, you know, we intend to share this, the draft report with those attendees to get their feedback. We also plan to share it with all of you. Or I'm sorry, we plan to share the final report as well with them once we get approval. We would love to invite their participation in the behavioral health workforce investment stakeholder engagement. And we're also thinking through, you know, what are some other ways we can continue to remain connected and engaged with those groups. Next slide, please. And so this is the point where we'd love to hear your feedback. You know, what are your thoughts? You know, are there documents that we missed or community groups that we should conduct a listening session with? Do the findings and our plans for future community engagement resonate? You know, and is there, you know, are there any changes that should be made?
Great. Thank you so much, Neelam and Mark. Excellent presentation, and thank you for leaving so much ample time for questions and comments from the members. I saw Ebony's hand first, so we'll go to Ebony and then Brenda.
Good morning, Neelam. How are you doing?
Good, Ebony. How are you?
Good. First off, I just want to say, you know, what an amazing overview presentation, very thorough. I appreciate hearing the intentionality around the listening and also, you know, the ownership for recognition of like information that has already been shared. And, you know, I think that this is one great way where, you know, y'all are being trauma informed and not, you know, causing folks to have to continue to retell. And so that was great to see and hear. Couple questions I have. I joined a few minutes late, so I'm not sure if I maybe missed it, but the first question I had was around behavioral health stakeholder engagement, and, you know, just wanting to know, you know, was there a list of behavioral health providers that y'all also interviewed, in addition to even the CMHPs who also are providers and also have the responsibility of assuring that there are equitable services across the board for, those with diverse backgrounds. So that's my first question. And then my second question is, in terms of kind of some of the key equity questions that you had at the end, I think those are great. And I just encourage y'all to be as explicit and really asking questions specifically of like who benefits, who specifically benefits from this policy, from this funding strategy, and who doesn't, are there unintended consequences? And if so, what are those? And then what's the strategy for then mitigating or resolving? But I just, encourage just explicit language, because I feel like overall, that's kind of what the questions got at, just as an example, but just, encourage that explicitness. So thank you.
Great. Thank you so much, Ebony. I think a lot of it, we're going to be really intentional about using those questions. We've even thought about, how can we incorporate them into our applications? And you're absolutely right that, we need to continually re-examine, our work against those questions. It's not a one-time thing. We need to use them on an ongoing basis. Mark, did you want to add something?
Only, Ebony, to your first question about did we speak to behavioral health providers, provider organizations beyond the QMH A's and P's? Yes, and we could get you the list of all of the organizations, perhaps in a different way, also separately after the webinar, so right. You can see the engagements that we did have in the behavioral.
Okay, and I guess my hope, if it's not too late and if it hasn't happened, is I highly encourage that there be some conversations with the community mental health programs or the CMHPs. So not QMHPs or QMHAs, but the CMHPs, the community mental health programs through the county, because there's a lot of rich information there. And, just because, I'm thinking about Multnomah County, for example, and I'm not sure if Multnomah County CMHP got interviewed, but there's a lot of rich information, sharing, learning. And I think there's, an opportunity for continuity and alignment too in, the work that we do. So thanks.
Great. Thank you for volunteering.
Yeah, I mean, we're completely open. We, recognize that we listen to a fairly broad group, but we recognize too that, there might be gaps even in our listening. So, please feel free to send us information. We're happy to continue to listen and incorporate any additional information we get into our framework.
Great. Ebony, thank you for those great questions. And Mark, if you want to share that list with me, we can also post it with today's meeting materials on the board's website with the recording so that everyone could see that full list that you were going to send to Ebony. Great. Brenda, please.
Great, thank you. I also, Ebony's compliments to the team, to Neelam, you and Mark, the Workforce Committee and the committee leadership for this incredible body of work. I know that it has taken the time and it clearly is evident in the results. My questions, I think I have two for both Mark and Neelam. What surprised you the most about the process? Now that you're kind of nearing the bend or closing it out, if you look back, you anticipated certain things you might hear or think about or be, just be known or reminded of, and other things that really surprised you. So I'd love to know what surprised you the most, either about the process or what you learned. And then secondly, where you think the heaviest lift is. There are a lot of recommendations. Some will be pretty straightforward. Others will be sticky and harder to accomplish. So I'm most interested in understanding which are the harder ones. Thanks.
Mark, would you like to go first, and then I can close out?
Sure. I'll give one surprise in the process and one surprise in the content, and maybe neither of them ought to have been a surprise, but in reflection, I recall being really struck. In the process, and maybe I should not have been surprised by this, I was surprised that groups that it was important for us, and it is important for us to hear from. It took something for many groups to get to us and to schedule. And to Ebony's comments about being trauma informed, in retrospect, I don't think that ought to have been a surprise. But from where I was, my initial thinking was, well, we're giving people the opportunity to really be heard. And the Workforce Committee has gone through this intensive training, and this is going to be great. So that was a surprise. And again, maybe it ought not to have been. The surprise in terms of content for me was the prevalence of what ought to be understood to be very simple around how patients are greeted when they come to present for healthcare. And it came up multiple places. And this may be an issue beyond like the clinicians. If you expand health professionals to the front desk staff, or to the medical assistant, or to the attending physician or physician assistant, we did hear frequently issues from advocates of community of color of how patients have not felt comfortable in when they're being received and when they're being treated. And that really struck with me, Brenda. So thanks for the question.
Yeah, and I would add what surprised me was actually how open some of the groups were that we talked to sharing. Very, very intimate and experiences. And so I was really humbled by that and honored that they, number one, took the time to meet with us, and that they, number two, they were willing to share that with us. And that was a huge gift that, again, I hope we can continue to build on. What I think will be the hardest lift then is also related is then how do we stay connected to these groups, given that it's a fairly small universe of groups that a lot of us are approaching for feedback. And so then how do we stay connected? How do we be respectful of their time and wisdom and community expertise, because there is a real value in that.
Thank you, Mark and Neelam. I can't help but wait to hear the answer to Brenda's second question about what you might think is the heaviest lift with the recommendations. Perhaps you're not ready to answer that yet, but that was on my mind too.
Well, Tara, I think that's what the October presentation is going to be illustrating, right? We've shared essentially the nuts and bolts, or the bare bones, if you will, of what the report will look like in terms of the content. And for sure, when we come to the board, we'll be prepared to speak about how to actually implement this framework in a meaningful way going forward, with both the Workforce Committee and our work within OHA and the Clinical Supports Integration Workforce Unit. So to be stay tuned for, I'd say.
All right, we will eagerly await that. Great teaser for the October meeting. All right, I see John Santa has his hand raised. John, please go ahead.
Yeah, well, terrific work. I was most impressed and interested, and hope we hear more about in October, that you all appreciate there's a lot of tumult out there. There's a lot of workforce that's not going back to where they worked before the pandemic. There's a lot of potential people out there that could come our way, your way. And you do have, it sounds like, resources to compete for those folks. And I would be very interested in hearing more and on an ongoing basis the degree to which you're seeing people shifting into especially behavioral health, where they're so badly needed. You know, on almost a daily basis now, I encounter, you know, especially in the hospitality industry, they don't have enough workforce. You know, yesterday it was interesting. We went to a restaurant to eat outside, and they did not have enough workforce to service, and told us, sorry, you're going to have to go elsewhere. So I think you really have an opportunity here because of the economic situation. The one thing I missed to some degree is, are there some organizations who in some respects are either best practices or competitors that it would help to hear, well, how are they doing? For example, when I was involved in workforce issues years ago, primarily trying to recruit physicians, Kaiser was far and away, I think, the most sophisticated organization in terms of approaching workforce and understanding the trends. You know, they were the toughest folks to compete with because they were offering better benefits and better environments and to more diverse populations. And as a Kaiser patient now, I see that when I go to Kaiser, I see a very diverse workforce every time I interact with them. And so, you know, in terms of these issues, where is a large organization like Kaiser? And how are they doing? And can we learn things from them? Are there opportunities in some cases to partner with some of those organizations in some way or other to get more workforce into Oregon? I'm not sure, but you know, so I'd wonder about a larger private side organization who has a big footprint in terms of workforce issues and how and what they're doing. So, you know, great work. Thank you.
Thank you very much for the question about best practices. I've made a note, and we should definitely consider that, especially as things continue to play out post-pandemic. My general assessment is that, as you said, we're in a very different environment than we were in 2 years ago. Even Kaiser's really great recruitment strategy may definitely be different now, and we should follow up to see how it's different now. One really great statistic I got from my colleague, Craig, I think yesterday, was that equipment online advertisement for open healthcare positions is double what it was prior to the pandemic. So no question about the tumult and that we're in a different time. I think your invitation to us to consider what are the best practices and to learn from what seems to be successful is really useful. Thank you.
Yeah, no, thank you so much for those really insightful comments and suggestions. I mean, I think you're right. And Mark also said that, you know, the future of work and workforce is changing, and we need to learn from what's worked in the past, but also be open to learning what is happening now, and how we can modify our approaches and learn from those who have done it well, and how they're modifying their strategies given all of the disruptions over the last year and a half.
Great. Thank you. All right. Laura McKean with All Care had a comment that she would like to make. So Laura, go ahead and unmute yourself and share your video if that's available and make your comment. And then I see we'll move to Ebony after that.
Hi, Tara. Can you hear me okay?
Yes.
Perfect. Yes, thank you. So my name is Laura McKean, and I am the Director of Oral Health Services for All Care CCO and also Vice Chair of the Healthcare Workforce Committee. And I get the opportunity to work with Mark and Neelam. And I just wanted to comment on the fact that I had the privilege and opportunity to sit in and participate in quite a few of these listening sessions that we did. And for someone like myself who lives primarily in the world of oral health, this really forced me to get out of my comfort zone. And I realized that we don't know what we don't know, and especially I don't know what I don't know. So this experience for me was really humbling and exciting. And you know, I'm going to follow next year our amazing current chair, Kurt Still, and I know that we have a lot of work to do, but I'm excited to get this work done and get it going, and I think we're going to do great things. So thank you, Mark and Neelam.
Thank you, Laura, for sharing that. Ebony, go ahead.
And I, you know, last things I'll just say, and, you know, some of you have probably heard me say this before, you know, we're talking about people's lives. And so it's a privilege to be able to sit around a table and to come up with strategies, recommendations. And I think I say this all the time, that we have those who are, you know, significantly impacted and that continue to suffer while we work to try to figure it out. And, you know, I do appreciate the current day and age where, you know, our current, you know, systems realize and are committed to, you know, finding some solutions, because again, we're at the mercy of the larger system dominant culture. And so it's a privilege. And so I'm glad that we're pushing ourselves outside of our comfort zone, because this is everyday life experience for people of color and those who are underserved. I also think it's important to, you know, look at, you know, because so a lot of this is rooted clearly in the issues of systemic racism that we find in our dominant systems, from medicine to education, so on and so forth. And so I think that it's important to remember that. And oh gosh, what was the last thing I was going to say? And yeah, so it's just a privilege. And yeah, you know, I forgot my thought that I was going to say that was super important. Oh, the Kaiser piece. You know, I also want to highlight the importance, and I don't know how we're able to, but surveying the members, just because I think that sometimes, depending on the day, the year, the decade, sometimes it seems as though the public sector is far more ahead in looking at how to integrate and sustain an equity lens and perspective. And oftentimes what I hear is from some of our, from members, whether it's Kaiser, you know, Blue Cross, Legacy, you know, a lot of dissatisfaction. And so I think it's important to also, while we go to the larger private sectors to understand what are their current best practices, I think it's important to balance that with getting the voice of the actual users of the system.
Great. Ebony, thank you so much for those comments. And that makes me recall that we are going to have an upcoming educational webinar from the Ombuds program. And they're going to share a little bit about consumer experiences from the Oregon Health Plan. And we'll also in the future hear from the Medicaid Advisory Committee on some of their consumer experiences work as well. Although that is a narrow population, we will hear some of that feedback, but thank you for sharing and lifting that up to all of us today, as well as Mark and Neelam. Mark and Neelam, we have 1 minute left. Any final closing remarks or thoughts that you'd like to share with the group before we end today?
I'll go. I want to specifically thank Oscar Arana for having really pressed the OHA staff well over a year ago now, a year and a half ago, to ask us before anyone was looking at centering on equity, really before anyone was thinking about an equity framework that's a formalized framework, for really starting this ball for the workforce committee and asking us directly, what is your equity lens? And that for me was the beginning of being able to even understand what is an equity lens, not just a set of implicit principles. And I want to thank him, Brenda, our liaison, and the committee, the board, and then also definitely the members of the workforce committee, such as Laura, for leaning in so powerfully and having this work be able to unfold.
Thank you, Mark. I really appreciate all the work that the OHA staff and leadership have put into this presentation. And I also want to thank all my fellow board members for their engagement and vision and guidance around this work as well. So I look forward to the report and our future conversations at the board meeting.
Thank you, Oscar. And thank you, Mark and Neelam, and all the members and all of the staff and folks who joined us this morning. We really appreciate it. This recording will be posted on the board's website later today or tomorrow, and I'll be sharing that link and of course, uploading that list of behavioral health community partners that Ebony had requested. So thank you, everyone. Have a great day, and we'll see you at the next educational webinar in September. Take care. Bye.
Thank you.